Welcome to the final session of the day, Fibrotic Lung Disease in Systemic Sclerosis. I'm Dr. Luke Evnen, Chairman of the Scleroderma Research Foundation. It's been an exciting and informative day, and I'm so pleased that you've stayed with us to the end. Before we begin, just a few quick notes. While this is officially our last Q&A of the day, we always love hearing from you and helping with whatever questions we can answer. Even after today, feel free to reach out to us at info@srfcure.org to ask us more about research and how you can help make a difference in the search for a cure. And as the presentations are almost done, that means that the virtual interactive activities are also almost done. Please go to the virtual challenge page to participate. And with that, I'd like to introduce Dr. Dinesh Khanna. Dr. Khanna is the Professor of Rheumatology at the University of Michigan, where he directs a multidisciplinary group of caregivers, scientists, and clinical researchers, all dedicated to advancing knowledge about scleroderma and related conditions. His research interests include developing new patient-reported outcome measures in patients. Now, Dr. Khanna is recognized as a leader in the effort to design better clinical trials for evaluating new patients for scleroderma. And in addition, he's leading international efforts to develop guidelines for the management of scleroderma and gout. And with that, let me turn the presentation over to Dr. Khanna.
Hello, everybody. My name is Dinesh Khanna. I'm a rheumatologist and director of the Scleroderma program at University of Michigan. I'm delighted to present on lung fibrosis and lung involvement in systemic sclerosis for the Scleroderma Research Foundation Day. Thank you very much for inviting me. Here are my appropriate disclosures, and I'll be talking about new therapies that have been recently FDA approved and also drugs that are in development. I think before we start, I want to clarify the terminology that I'll be using today. I'll be using interchangeably words such as scleroderma and systemic sclerosis to highlight for systemic scleroderma. I also want to clarify that interstitial lung disease, ILD, or lung fibrosis are one and the same thing, so I might use that interchangeably too. So let's start about systemic sclerosis or scleroderma-related interstitial lung disease or lung fibrosis or ILD. Scleroderma-related ILD affects approximately 7 in 10 people who have systemic sclerosis. Of those, 1 in 3 people develop progressive ILD that may require treatment, that may require other aspects such as oxygen therapy, and may progress to lung transplantation. We know, unfortunately, that it continues to be the leading cause of death in scleroderma despite having different FDA-approved therapies. The lung fibrosis is largely irreversible, so once we have a certain degree of lung fibrosis, we can't revert it back to normal, and the goal of the treatment and management is stabilization. And finally, the therapies right now, apart from education, immunization, oxygen therapy, includes immunosuppressive therapy and antifibrotic therapies. On the right is a CT scan or a CAT scan of a patient who has interstitial lung disease, and I'm showing you quite a bit of fibrosis with my cursor out here, and you see the heart in the middle, and you see the left part of the lungs on your screen. One thing that I want people with scleroderma to take is that interstitial lung disease is an earlier complication of systemic sclerosis. Here are patients who have diffuse cutaneous subset, also known as progressive scleroderma, and you can see that interstitial lung disease usually happens in the first 2 to 5 years after onset of scleroderma. The same thing is seen in patients who have CREST syndrome or limited cutaneous scleroderma, and you see in this patient population that ILD is also an earlier complication. Why is that important? Patients should be screened carefully and managed aggressively, especially in the first 5 years after onset of your disease. There are scleroderma-specific autoantibodies that are critical in defining whether you'll have very significant ILD or progressive ILD, or whether you will have mild ILD. These autoantibodies are listed here, and I will just go over the first three autoantibodies. Centromere antibodies are seen in approximately 20% of people with scleroderma, and the risk of severe ILD is rather small, which is good news. And the subtype of disease is limited scleroderma. On the other hand, if you have topoisomerase 1 antibody, there's a very large risk that you will develop progressive or severe ILD, and the subtype is diffuse scleroderma. And finally, you have RNA polymerase 3 antibody, where the risk is medium, somewhere between centromere and anti-topoisomerase 1, and the type of scleroderma is diffuse. Your physician should be testing for these autoantibodies during the initial visit that you have with the scleroderma center or any rheumatologist that can help us define the risk of progressive lung fibrosis. And finally, although you develop lung fibrosis in the first 5 years of onset of your disease, the greatest decline in lung function happens in the first 2 to 3 years. So this is a study from Dr. Steen at University of Pittsburgh, where she shows that the decline in lung fibrosis, approximately 30% of the decline, that's a very large decline in your lung function. You have lost 30% of your lung volume on an annual basis, occurs during the first 2 years, and over time, the decline kind of stops or plateaus over. I told you that this decline is irreversible. I rather treat a person and maintain their lung function here rather than start the treatment somewhere 2 to 5 years down the road where I cannot revert back or reverse back the damage and fibrosis that already has been done. Let's talk a little bit about diagnosis of interstitial lung disease. And we'll focus on 3 different aspects: symptoms, and we'll talk about symptoms such as shortness of breath, cough, fatigue, not feeling well, lack of energy, and so forth. Pulmonary function test, PFT or lung function test, and then imaging studies. So symptoms are important. That's why patients come to us. You go to a doctor when you have a cold, when you have a cough, you're not breathing well. Unfortunately, symptoms usually occur later in the disease regarding lung fibrosis, once approximately 20 to 30% of the lung has been involved. And that is not good. It's an irreversible disease. We want to capture you early on. The other part is when you have scleroderma, you have a multisystem disease. You may have symptoms of shortness of breath because you have heart involvement. You may have cough because you have acid reflux. You may have muscle involvement that would limit your activities and give you shortness of breath and fatigue. And finally, one of the other key complications, pulmonary arterial hypertension, also comes with increasing shortness of breath with exertion and sometimes cough. Let's talk a little bit about pulmonary function test. I'm sure all of you have gone through this. It is a breathing test where you blow into a machine. It takes about 30 to 90 minutes. And there's a pulmonary tech that monitors those curves that are shown on the right upper aspect of the panel. This is a very important test. It can be tedious, it can be tiring, but it gives a reflection of how are your lung volumes. It doesn't tell us whether you have lung fibrosis or not. All it tells us is whether the volumes are normal, the amount of lung air that you have is within what we would expect for age, gender, and height. I'm seeing you 3 panels out here that shows that this person did it reliably. They were similar in the 3 different trials which we want within the lung function. And then there's a lung volume in the right lower panel, which can help us distinguish whether you have certain diseases such as COPD, obstructive lung disease due to smoking, asthma, or you have a restrictive lung disease such as due to pulmonary fibrosis or ILD related to scleroderma. I told you that this is done in a pulmonologist office. It takes about 30 to 90 minutes, provides detailed information on lung function, but does not make a diagnosis of ILD. I think that's a critical aspect. Many patients are confused. Why do I need a CT scan if I'm getting a pulmonary function test? The normal lung function can range between 80 to 120%, and that's a problem. If you came to me and you said my lung function is 80% and you never had a lung function before, I don't know whether you started at 120% and have lost 40% of your volume, or you really started at 82% and you really have not lost much lung volume. It can be normal in 1/4 of the patients who have ILD. So the lung function is quote unquote normal, but you have significant lung fibrosis, and it can be abnormal due to poor fit of the mouthpiece, as you see in this patient here, or muscle weakness. So all these different aspects are very important. You go to the right physician, the right pulmonologist who are used to taking care of patients with scleroderma. And then, of course, we do chest X-ray or radiograph and CT of the chest. And I want to give you a historical description how things have changed since 1990. In 1990s, rheumatologists and pulmonologists used to do chest X-ray to find late lung fibrosis. And they only used to do it if you were symptomatic. In 2000, people started doing the CT of the chest, and you see in this patient quite a bit of lung fibrosis over my cursor, whereas this part of the lung is the normal lung. We could glean more into the lungs, what is happening, get detailed information on the kind of fibrosis you had, but we still waited for symptoms to occur. In 2010, we got a little bit smarter, irrespective of the PFTs. We were doing CT of the chest, but still doing it only in patients who were symptomatic. And in 2022, we have become very aggressive appropriately because we want to diagnose early ILD. We have FDA-approved therapies for it. And we do HRCT or the imaging irrespective whether you have symptoms or not, or whether your lung function are abnormal or normal. Now, one of the key concerns of the physicians and the patients is the radiation that is associated with the CT scan. There are a few reasons you should not get a CT scan if you're pregnant or you're breastfeeding, but otherwise, the CTs now have very effective radiation, and I will give you some data to support what I just said. If you live in the United States of America, you are exposed to approximately 3 units, which is called millisievert units of radiation every year. If you are an airline crew member on long-haul flights, you get an extra 2 to 3 millisievert every year. So annually, all of us get about 2 to 3 units of radiation every year just by the virtue that we live in the US. Now, when you look at chest X-ray, and that's why people tend to do chest X-ray, the radiation is effectively very, very minimal, almost zero. However, chest X-rays are not very good at screening a patient with early ILD. They are very good when you have significant ILD with symptoms and shortness of breath and other complications. What we do at University of Michigan is a standard protocol. With a CT scan, we ask people to take a deep breath in, hold it, deep breath out. We put you on your back and on your abdomen, trying to get all the pictures to see whether you have any evidence of ILD in part of the lungs. And what I tell patients is that the amount of radiation is similar to what you would receive just based on one CT and is compared to the annual exposure from background radiation in USA. And that's an important information for the patient to have. We only do CT one time, unless until there's a reason to repeat it, you're part of a clinical study or other aspects. In our mind, the benefits clearly outweigh the risk of knowing whether you have lung fibrosis or not. And if you do have lung fibrosis, is it mild, is it moderate, is it severe, and helps us define the treatment that we should be giving you. So here's a patient of mine. Here's a CT of the chest. It's a front view. You can look at the chest, or the air in the chest is always black. On the CT, you have the heart in the middle. This part is the right side of the lung, and this part is the left side of the lung. And you see the vessels within the lungs that are normal, and you see the pulmonary arteries out here and the bronchus. This is an up-down view of the chest. You're looking at the heart level. This is the heart, and again, you see the lungs, and you see the appropriate vessels. So this is a patient with scleroderma who does not have any evidence of ILD. And this is what an autopsy of a normal lung would look like. You would see, again, the vessels that you see out here on the CT. So you can see the vessels and the different connections that are happening with the airways out here. Here's a patient who has something called non-specific interstitial pneumonitis. And you may be asking, Dr. Khanna, why are you telling me about NSIP? Doctors will use this lingo. there may be new treatments that may be effective for NSIP, which is more inflammatory, as you can see out here with inflammation and fibrosis, compared to something what we call UIP, which is more fibrotic and damaging. And in fact, here's a patient who has a UIP or usual interstitial pneumonia pattern where you see honeycombing. So if you ever seen a honeycomb, these look like honeycombs out here, and this is very classical for UIP pattern. And here is an autopsy picture of one of the patients where you can see these honeycombs in the lungs. And you can see these honeycombs can destroy these fragile alveoli or air sacs that connect with each other. And that's how you inhale oxygen and it gets diffused or circulated throughout the body, and then you exhale carbon dioxide. So let's talk about the treatment of progressive ILD. Not every patient with ILD requires immunosuppressive or pharmacological treatment. However, every patient with ILD should be educated, should be up to date with immunization, including the COVID vaccines, and every scleroderma patient should have received 2 booster doses if you had the mRNA vaccine. Oxygen therapy, if on your saturation on rest or walking is less than 88%, and do not forget the role of acid reflux. You sleep at an angle, you prevent that acid going into back of the lungs while sleeping. Manage your symptoms with proton pump inhibitor. You do not want that acid or non-acidic reflux going into the lungs and irritating your lungs. Now, the management of scleroderma ILD, like I said, 70% of the patients have evidence of ILD on CT of the chest, of which 30% develop progressive ILD. If your doctor believes that you are a candidate for early treatment, which I believe most of the patients are, because it's an irreversible progressive disease, then we believe you should require some kind of a medication, either IV, by mouth, by injection, and we will talk about that. And the treatment early on is to treat your scleroderma, treat your autoimmune disease with the drugs that we know call immunomodulatory or immunosuppressive therapies that can calm down your immune system that is a bit dysfunctional, it is quite hyperactive. And if those drugs don't work, then we would think about adding an anti-fibrotic therapy to the regimen. And there are treatments and trials going on that are trying upfront combination therapy, combining an immunomodulatory therapy along with an anti-fibrotic therapy. So what are the therapies that we use? And when we do question and answers, it would be a great opportunity to talk about the therapies that you are on. But largely mycophenolate mofetil or CellCept is the go-to drug. In fact, 80% of all people in US who have scleroderma ILD are treated with mycophenolate mofetil. It used to be, we tend to use a chemotherapy in low doses called Cytoxan, but due to the significant side effects, most of the rheumatologists and pulmonologists use CellCept for the management of it. There are 2 new drugs, Tosoluzumab or Actemra, and nintedanib or Ofev that we will talk about, and I'll talk briefly about the stem cell transplantation for ILD. So let's start with nintedanib or Ofev. So nintedanib is a groundbreaking drug, and it was FDA approved, the first therapy ever approved for scleroderma ILD a couple of years ago. And it's an intracellular, meaning within the cell, protein inhibitor of a protein called tyrosine kinase that can bind to receptors that cause fibrosis in the lungs. So it's a very novel way to bind to different receptors and preventing the signaling of those receptors and into the cells that may activate the fibroblast and cause fibrosis. This was seen in a clinical trial. Anytime you get a drug FDA approved, there must be a very large, robust clinical trial where the benefits clearly outweigh the risk. I want to go over the data because it's important if you're taking the drug, you know what the data shows. So here is a decline in the lung function test, a test called forced vital capacity, where you breathe hard outside for as long as you can, and the pulmonary tech will keep on pushing you to do that. The lower the decline is bad. You know, here are patients on average who got the drug declined by 52 ml. And on the placebo, fake drug, matching placebo, the decline was 93 ml with a difference of 41 ml. Another way to look at the data for clinician and for patients is patients who were on nintedanib had less decline of their lung function compared to placebo. Now, it is important to know who are the patients who got the drug, and this is shown in this slide. Half the patients were diffuse scleroderma. That means half the patient had limited scleroderma. It is applicable if you have ILD, whether you have diffuse or limited. I told you that ILD is an earlier complication. The average age was 3.4 years. There was a lot of fibrosis on a 0 to 100 scale. 36% of the lung had evidence of fibrosis. That's quite a lot of fibrosis. And when you look at the forced vital capacity, I told you 80 to 120% is normal. The average forced vital capacity was 72%. So these patients had symptoms. They had a lot of fibrosis. They were in the first 3 to 4 years of their disease. And after adding nintedanib to their treatment, they had less progression of their lung function. Another very interesting part of this study was that approximately half the patients came on background CellCept into the study. And you see when nintedanib was added to CellCept, it was more effective compared to if the patients were just taking nintedanib. So using this data, most of the rheumatologists and pulmonologists add nintedanib to the background CellCept. One of the things that we saw in this study, it had no improvement in your skin score, no improvement in your fatigue, no improvement in your quality of life and other aspects of scleroderma that dampened the enthusiasm that it can be used as a treatment instead of an immunosuppressive therapy such as CellCept for the management of early scleroderma. And there are important side effects that the patient should be aware of, because if you're not aware of this, you are not going to continue to take this medication. So here are the patients on placebo, and you can see people who are getting placebo or a sugar pill, 31% of the patient had diarrhea, 13% nausea, and 10% vomiting. In contrast, nintedanib, there was a much higher proportion who had diarrhea, nausea, and vomiting. And this is a known side effect of the drug. The patients need to be educated. They need to come up with a plan with their doctors on how to manage these side effects. And most of the patients are able to tolerate it working with their physicians. The other drug that was approved by the FDA is called Actemra or Tosoluzumab. And it's a very interesting drug that tries to prevent the action of a protein or a cytokine called IL-6 or interleukin 6. IL-6 binds to its receptor and goes into the cells and causes inflammation, fibrosis, immune activation. And Tosoluzumab or Actemra binds to the receptor. So this is Actemra, it binds to the receptor and it prevents the IL-6 to bind to its receptor out here, and it prevents any of these inflammation, fibrosis, immune activation from happening. It is FDA approved for rheumatoid arthritis, juvenile arthritis, giant cell arthritis. It is now FDA approved for cytokine storm associated with COVID, and also approved for scleroderma lung fibrosis. So this is a study that I had designed in conjunction with Genentech and Roche, and the patients that we included were very different than what we included in Census. We took people with early diffuse scleroderma and we wanted to soften their skin. We did a CT on every patient, and we found that 66% of the patients who came into the trial, in fact, had lung fibrosis. So here's a patient with a little bit of lung fibrosis, and here's a patient who has almost 30 to 40% of the lungs that has scarring and inflammation in their lungs. So what you should know as a patient, that if you have early diffuse scleroderma with quite a bit of skin involvement and elevated acute phase reactant, CRP or ESR, you have 6 in 10 chances that you have early interstitial lung disease. And most of these patients had normal lung function tests, as you would expect. The only way we were able to diagnose and detect ILD was on the CAT scan. The data was spectacular that led to the FDA approval of this drug. Here are the patients in red who got Actemra, and they had preservation of their lung function. Remember, I told you I can't improve this lung function, but the drug led to stabilization of lung function. On the other hand, the patient on placebo had this very large decline in the lung function. Now, when these patients went on open label, we were not able to revert it back to normal. These patients we could just stabilize, but cannot turn back the clock. What has happened will continue to remain with you for the rest of your life. Safety of Actemra, there are risks of infections. You need to get regular blood work and for blood count and liver function tests. In the clinical trial, the effect or severe side effects or infections were no different between the placebo and Actemra. I want to finish my talk by talking about stem cell transplantation, which is a very important and a critical aspect of management of scleroderma lung fibrosis, and then briefly talk about new treatments. This was a pivotal trial led by NIH where we randomized people to bone marrow autologous, that means your own stem cell, followed by total body radiation or giving you chemotherapy on a monthly basis for 12 months. Who were the patients? So let's look at the transplant patients. They were much younger, 44 years. Half the patients were female, very early disease, approximately 2 years of disease duration. Everybody had lung involvement and the lung function test of 74%. And everybody had diffuse scleroderma. So significant of about lung fibrosis not responding to CellCept or any therapies who are offered autologous stem cell transplantation. And here is the data that excited the whole world. And I would like to just focus on the right panel on overall survival. Patients who had stem cell transplantation after approximately 5 years, the survival was 90% compared to the gold standard at that time, the chemotherapy on a monthly basis continue to decline and unfortunately die. And you can see even during the follow-up, about 50% of the patients have died. So for a selected subset of patients who have progressive disease not responding to Actemra, nintedanib, or CellCept, this is something that patients should be aware of, and we do it quite often at University of Michigan for patients who are not responding to our traditional therapies. Let me give you a glimpse into what happens to lungs after stem cell transplantation. So the top panel is a patient over time who got Cytoxin, and the red and blue is amount of fibrosis at baseline, 14 months and 54 months. And you see that blue and red panel out here is increasing over time, meaning there's a lot more fibrosis this patient is developing. One thing that potentially can reverse back early lung fibrosis is stem cell transplantation, because you have reset your immune system. Your thermostat has been reset. You have a new air conditioner and heating. So everything is new. And you can see in this patient, the colors of the lung fibrosis in yellow, red, and blue, and over time, it has really diminished to something from 42% to 14%. So something very exciting, but lung transplantation or stem cell transplantation is not for every patient. So where do we move in the future? I think we are moving towards the precision medicine initiatives such as Tosoluzumab, taking early diffuse patients with elevated acute phase reactants and using targeted therapy. Upfront combination therapy, we do it in pulmonary arterial hypertension, rheumatoid arthritis. Why not combine nintedanib, an FDA-approved drug, with mycophenolate or Actemra? We want decreased toxicity. We want stem cell transplant-like effectiveness, but not the toxicity. And I want to highlight a very exciting initiative with Scleroderma Research Foundation, and that we have worked together as a team, an international team, to launch what is called a platform trial design. This is my last slide here, and I want to share the platform trial design, which by definition is a master protocol, and there are 3 drugs, drug A, drug B, and drug C, that can be tested on the platform in patients who have scleroderma ILD, and there's only a shared placebo group. So if you are a patient, there's 3 in 4 chances that you will get one of these investigational therapies compared to the placebo. The 3 platform or trials can go parallel to each other, and the placebo from each of these groups can be shared, and you can compare each therapy to the shared placebo group. This is being launched later in this year, and I'm very thankful for the steering committee and Scleroderma Research Foundation for coming up with this very brilliant idea and innovative idea. So I thank you for your participation, and I look forward to answering your questions. Good day.
Well, welcome. I just want to congratulate Dr. Khanna. I thought that was just a fantastic introduction to fibrotic lung disease and scleroderma. Covered a huge amount of ground in just a few minutes, and so I think we owe a huge thank you for such a comprehensive and thoughtful presentation. So thank you. But let me dive right in on a couple of audience questions, and so we can talk a little bit about some of the other things that that you did touch on that would be useful to go back into. But maybe on the questions, there's a couple questions about COVID-19. Obviously, it's impacted all of us. Implications for the disease, though, as you know, in scleroderma. So two questions. How should one think about symptoms of COVID from an exacerbation of their ILD, and then separately, I mean, how worried should a scleroderma patient be? Does it actually trigger basically worsening of the fibrosis? And those, I guess, are slightly related. Please.
Yeah, thank you, Luke, and thank you for the opportunity in putting together this fantastic symposium today. I think it's great for the patients to be able to participate in this. So I think the first question is, what is COVID lung versus scleroderma, ILD, and flare? And I think my advice to our patients at Michigan has been that if you are not feeling well, it is best to get tested either at home using the rapid antigen test, or preferably doing a RT-PCR that is done at a doctor's office. Because sometimes it's very difficult to distinguish if you're getting more short of breath and you don't have any other symptoms, whether it is related to an infection, whether it's COVID, flu, and another viral illness. So it sometimes becomes very difficult to tell. On CT of the chest, we can clearly differentiate what is worsening of lung fibrosis versus what is being caused by COVID. So there are telltale signs that are different between the two. So, I hope that answers the question. But if you are worried at all, it is best to get a home antigen test. And the guidelines from the CDC for the home antigen test is that it may be negative during the early part of the disease. And if you repeat it in 48 to 72 hours, and if it's still negative, it is highly, highly accurate that you do not have COVID. So I want to repeat that. You do it at home, you repeat it in 48 to 72 hours, and if it's negative again at home, it's highly unlikely that you have COVID infection. Now, the second question is, a person with scleroderma and ILD who is likely on mycophenolate, Tosoluzumab, nintedanib, or other therapies are immunocompromised. People who have COVID and ILD are more likely to can develop severe ILD or worsening or exacerbation due to the COVID virus. So there are a few things that you can do. The first and the foremost important thing is get your COVID vaccinations. And for people who are on mycophenolate or Tosoluzumab who are immunocompromised, the primary series per the CDC is not just 2 injections. So we all have been told that you just take the 2 mRNA, Pfizer or Moderna. If you're immunocompromised, you should be going for 3 injections as primary series, 4 to 8 weeks apart, followed by 2 booster doses. So there's absolutely no reason for you not to take booster doses. The second advice I have is that we know that if you're on mycophenolate, and especially if you're on rituximab, and some of the scleroderma ILD patients are on rituximab, that makes the COVID vaccine less effective and sometimes, really ineffective. So just because you had a COVID vaccine does not mean that you are protected. Now, I'm not trying to scare you, but you need to continue to wear a mask, and your doctors can do a test, an antibody test in their office that is sent out that can tell you what kind of immune antibody response have you had to the COVID vaccine. And finally, Luke, a pitch, there's an NIH study that is going on that I'm one of the PIs on, patients with scleroderma, lupus, or rheumatoid arthritis who have had COVID vaccine or boosters and have still not responded on this test. are eligible for additional COVID vaccines, whether they're mRNA or new vaccines that are being developed. So be careful. Do not assume that you had the COVID vaccine, that you have appropriate antibodies. There are ways to test it and continue to, keep the distance, wear mask and things like that if you're taking immunosuppressive therapies.
Thanks, Dinesh. There seems to be a number of questions just about some of the jargon that patients are hearing from their physicians, and maybe we could help just guide some folks. So, what is the value of DLCO? Maybe we can define that for patients. And then separately, or partly related, on the HRCT, there's different patterns of fibrosis, honeycombing and other, patterns. Is it, are there particular diagnostic versions, and what's sort of paradigmatic of different trajectories that might be useful to have patients hear about?
Absolutely. So DLCO, or the diffusion capacity of hemoglobin, is really the transfer of oxygen. When you inhale oxygen into your lungs, they go into the air sacs or alveoli, and they diffuse into the blood vessels. And when you exhale carbon dioxide from your body, from the blood vessels, the carbon dioxide comes into the air sacs and you exhale it out. So the diffusion capacity is really a measurement of this diffusion or transmission between the air sacs and the blood vessels. And, it's a very intricate phenomenon that we all fortunately have. What happens in scleroderma lung fibrosis, what happens in COPD, smokers, emphysema, that there's a destruction of these airway sacs. And maybe, if it's okay, I can share just to show you what I'm talking about here. And these are the slides that I had presented. So this is a normal autopsy of a person who doesn't have lung fibrosis. And there are air sacs that are throughout these lungs that you cannot see at a microscopic level, that is diffusing the oxygen and the carbon dioxide. Now, what happens in scleroderma, and this goes to the other question, honeycombing or UIP you were talking, think about, you have all these destructive lesions out here, and there's no appropriate diffusion that is happening between the blood vessels and the air sacs because the sacs have been destroyed. So now you have these big honeycombs out here that is preventing that effective diffusion that is from happening. A low diffusion capacity may happen because you have lung fibrosis. A low diffusion capacity may happen because you have low hemoglobin, because the way it is done is the diffusion capacity, it binds to your hemoglobin. But the most important reason for a low diffusion capacity, unfortunately, is not having the right pulmonary function tech or having the right apparatus or device to be able to do it. People with scleroderma have smaller mouths, so you need to go to a PFT lab where they can use the pediatric mouthpiece. This is the biggest reason for a low diffusion capacity, the error of doing and not having an appropriate tech that can help you do it. Now, Luke, to your other question, and these are the slides that I talked about. So there are a lot of these terminologies thrown at people called NSIP or UIP, and what they are both forms of lung fibrosis. So they're both form of lung fibrosis. Here's a lung of a person who does not have ILD, and you see the heart, and you see the blood vessels, and the normal lungs are always black in color, and you see the normal lungs, and you see the food pipe here. Now, when you look at a patient with NSIP, you see the fibrosis out here, and you see something called ground glass opacity. What it in English it means is that there's quite a bit of haziness. I'm not able to see the architecture of the lungs. A UIP pattern is where you see the honeycombs. So if you think about a honeycomb, these look like honeycombs, and this is a patient of ours at University of Michigan, and this is a honeycomb. Now, UIP without scleroderma is also known as IPF. So if you had a UIP pattern, if you are an older male, usually this would be called idiopathic pulmonary fibrosis. It doesn't matter. because the treatment that we have, including nintedanib, is quite effective both for UIP and NSIP patterns. This is a more fibrotic part of the disease, and this is a more inflammatory part of the disease. If you have scleroderma, 90% of the patients, both in the nintedanib trial and Tosoluzumab or Actemra trial, belong to NSIP, and 10% belong to UIP. On the other hand, if you have rheumatoid arthritis, majority of the patients have this UIP pattern.
That's super helpful. It's very clear. Thanks so much. You talked a little bit in your presentation about multi-component regimens and maybe the future of drug therapy. Maybe it's worth just revisiting that as we get close to wrapping up and talk a little bit about multimodality therapy, and maybe it would be interesting to have you sort of project into the future about what you think might be on the horizon for scleroderma patients.
Yeah, thank you, Luke. I think it is fantastic that we have 2 drugs that are FDA approved. It is great that we have stem cell transplantation that is really changing the lives of people who have early lung fibrosis. I think when we gleam into the future, in my mind, we are trying to combine 2 different therapies that can maybe give the effectiveness of the stem cell transplantation but reduce the toxicity. So think about 2 FDA-approved drugs, Tosoluzumab and nintedanib or OFEV. Can you combine Actemra, which is an anti-inflammatory, targets abnormal activated immune system, versus taking nintedanib that's more of a potent antifibrotic? Why not combine upfront both those therapies and try to be more aggressive targeting these things? We are learning quite a bit about the lung fibrosis. You have led the initiative on the Conquest, and I showed a slide on Conquest where we will be doing platform trial designs. So I think the future of scleroderma ILD is early diagnosis, early screening, early treatment, but hopefully upfront combination therapies. And we do that in rheumatoid arthritis. And I know the lecture before me was on pulmonary hypertension, and you heard upfront combination therapy for pulmonary hypertension, and that's the field or the way of the future in my mind for scleroderma ILD.
Great. Let's see.
There are a lot of questions on COVID. I think one question that I would like to answer here is the use of Huetwell. So Huetwell is a monoclonal antibody by AstraZeneca, and it is FDA not approved. It's part of the EUA emergency use authorization in patients who are at very high risk of developing COVID and your immune system has not responded appropriately to COVID vaccine because you're on immunosuppressive therapies. So classical patients are patients who are on cancer immunotherapy. But if you're on Cellset or rituximab, that's something that you should talk to your rheumatologist.
Thanks, Dinesh. There's also, again, going back to diagnosis and prognostic power of different monitoring regimens. Do you favor, it sounds like you favor HRCT, but are there other functional measures like the 6-minute walk test or other measures of say, exercise tolerability that you favor as just a way to monitor someone's basically progression in their capacity? That might be helpful for patients to learn a bit more about.
Yeah, absolutely. So there's only one way to diagnose interstitial lung disease, and that is doing an imaging study. And we prefer CT of the chest because it is more sensitive to do it. However, with CT comes the risk of radiation. So you don't want to do CT on every ear and give that additional risk of radiation. So once you make the diagnosis, the way we follow patients are, like you pointed out, Luke, pulmonary function test. So we tend to do it every 4 to 6 months early on to see whether the lung function is declining. We do a hall walk test where you walk for 6 minutes with or without oxygen. And the distance that you walk, we keep an eye on it and what happens to the oxygen saturation when you're walking. When you go to a pulmonary function lab to get this done, make sure that they put the lead to measure oxygen saturation over your forehead, because if they put it on your finger, they will show abnormally low oxygen saturation just because you have Raynaud's phenomenon or if you have digital ulcers. Symptoms are critical. We ask people, are you short of breath, coughing, and things like that. However, the disadvantage of symptoms is that a quarter of patients with ILD have no symptoms because people with scleroderma have body aches, fatigue, tiredness, muscle involvement, or the symptoms of shortness of breath may come from, as you heard, pulmonary hypertension, anemia, just lack of energy, or interstitial lung disease. So diagnostic pathway is CT, follow-up, lung function test, hall walk your symptoms, and other aspects.
Thanks, Dinesh. I'm sorry, I think we have run out of time. You've been incredibly generous with your time today. I hope we've answered most of our patients' questions. And again, thanks everybody for a great session. We'll be following up. Bye-bye now.